we're going to talk essentially about the Oedipus complex, both in the boys and the girl, and the importance that phase has in the organization of the personality and in the organization of all the conflicts that preceded that phase into one single organization that is then called the infantile neurosis. At the same time, that phase has, with the resolution of the Oedipus complex, the superego structure gets more finalized and gets the authority to impose the commands that before it lacked. It lacked the authority to, it may have had the introit but not the authority to impose the rule of law, so to say. After that, we're going to talk on addressing development, fixation, and regression, and the relevance of that for the psychoanalytic theory, the neurosis. But before we get there, I want to go back to the previous lecture where we were talking about the phases of autoerotism, primary narcissism, object cathexis, and then the return of the object cathexis in the form of secondary narcissistic cathexis towards the self, coming from the object towards the self. In other words, when you invested in the object returns some kind of interest for that investment, and that's called secondary narcissistic cathexis. What I wanted to highlight for you was that in this case we are talking of what Freud called libidinal positions. In other words, where is the libido? Whether it is in the autoerotic activities before there is a primitive concept of the self, whether then it goes to the self in the stage of primary narcissism, and whether finally it goes to the object world, and that's why it's called libidinal position. Where is the libido? Is it in the self or is it in the object? And that should be differentiated from the libidinal phases of development, which are the oral, anal, phallic, Oedipal latency, and so on, which is a different kind of level of conceptualization, as we have seen in the past. So it is important to distinguish between what are libidinal phases of development and what are libidinal positions, which is what is implied in dividing the stages in autoerotism, primary narcissism, object relationship, and from there then secondary narcissistic phenomena. Coming back to the Oedipus complex, we need to highlight essentially that the girl's Oedipus complex is considerably more difficult to manage, difficult to understand, and much more complex than that of the boy, and it has a variety of different variations from that of the boy. Indeed, the boy has a much easier time, as we will see in a moment. If you take this page that will be available in the web page, that can be downloaded from the web page, and keep it at hand, you download it and keep it at hand, then we will deal with the different issues that are involved here. First of all, let me call your attention to the fact that I have called, in this diagram that you see here, the girl has a first stage of the Oedipus complex and a second stage of the Oedipus complex. And the first one is called phallic Oedipal, and the second one is called Oedipal. And the reason for that, as you will see in a moment, is that the girl behaves like the boy towards the mother originally, and then has the other difficulty of having to exchange the object mother for the object father, and that's the final form of the Oedipus complex of the girl, or the more normal aspects of it. In the scheme, as you will see, there is this round circle with an arrow going up, which represents masculinity, and there is this little circle here with a plus sign on top of it, which is a symbol of femininity. And what we're trying to say with that is that in order to understand this scheme, all you really need to do is to understand the concept of bisexuality and how the cathexis, whether they are heterosexual or homosexual cathexis, what kind of object, or rather whether they are masculine cathexis or feminine cathexis, what kind of objects they are going to go and look for. The concept of bisexuality is an important one and is well based in psychoanalytic theory, and of course it has a root in biology. As we all know, males do have circulating in the body feminine hormones, and women have masculine hormones circulated in the body, which means in the hormonal sense there is a bisexual component to every human being, and beyond that, as you know from embryology, though at the beginning, not at the beginning, but many years ago, the idea was the clitoris was an atrophic penis. Nowadays, through new embryological findings and knowledge, we do know that in fact it's the other way around, that in a manner of speaking, the penis is a hypertrophic clitoris. In other words, the initial matrix is a bisexual one, from which either a female development can take place or a masculine development can take place. And what makes the difference is whether you have two X chromosomes, in which case you'll be a female, or you have an XY chromosome, in which case you will become a male. And from that feminine matrix, either a woman or a man will develop. What makes the difference is that if you have a Y chromosome at some point, embryologically in the development of the fetus, there will be a hormonal bath that changes the direction and move that basically feminine matrix into genitalia of a male. In other words, develops a penis and testicles and so on, rather than labia and vagina and uterus and things of that kind. So the concept of bisexuality is important in psychoanalysis for many reasons, as we will see in a moment. Indeed, it is said that there are some species of animals, the one that I am familiar with is fish, that are called Siamese fish, fighting fish actually, which, as you know, you cannot put two males together. But if you do that, they will fight to the death. One of them will be killed. And it is said that the reason for that is that this fish only has masculine hormones, no feminine hormones to tame the behavior. And consequently, they fight to kill each other to the death, which seems to imply that the feminine component in males make it possible for one to be friends with other males and have a close relationship to them without necessarily having any other sexual implications. That seems to be more difficult if that were not the case. In any case, bisexuality then has two components. Has a masculine component and a feminine component, and there is a balance between how much masculinity and how much femininity there is, and that's very variable from one child, let's say a masculine child, to another. There may be kind of more tendency to masculinity, more marked, more significant, more visible in behavior, ego interest and things of that kind in some boys, that in other boys that are a little less masculine that way, still masculine but less so. In other words, there are variations in this regard, and that's usually or conceivably genetically determined, though there is no question that certain environmental experiences may enhance or make the manifestation of masculinity a little more difficult in some specific cases. In any case, if we go back to the scheme And I need to tell you, before we just do that if you think of the masculine cathexis, which is the one with an arrow, whatever is a masculine cathexis, tend to look on the normal condition for a feminine object. So masculine cathexis look for an object of the opposite sex, which will be a female in this case. In the case of feminine cathexis that are represented here by the plus sign on top of a little circle, the feminine cathexis of the bisexual constitution, that aspect of the bisexual constitution that is made up by the feminine elements of it, goes for an object of the opposite sex. In that case, it will be a male. Now, if you take then the scheme, there are two stages, and I know that that's not visible in the camera possibly, but if you have it in your hand, you can follow what I'm saying. The first stage is on the left part of the page is the first stage called phallic Oedipal, and then on the right side of the page there is the second stage called Oedipal. Now, if you take the bisexual constitution of the little girl at the time of that the boy reaches the Oedipus complex, she is essentially in a similar position to that of the boy. In other words, she will cathect the mother. With the masculine side of a bisexual constitution, and insofar as she does that, the father is a rival for that relationship. And that will be called the positive Oedipus complex. In other words, the little girl at this point, the first stage of the phallic Oedipal phase, is taken like the boy, the mother as an object of her interest, and the father becomes a rival. Now, that's with the masculine side of the girl's bisexual constitution. With the feminine side, that goes to an object of the opposite sex, that is the father, and insofar as she has a lot of femininity in her, actually, that at this point perhaps is not manifested as strongly as it will in the second part of the Oedipus complex, because she's still attached to the mother, so it's the masculine cathexis that go to the mother. Then, with the feminine side, though, she cathects the father. And insofar as she is interested in the father, with her feminine side, the mother becomes a rival in that relationship. Now, you should notice that at this point, the arrow is larger than the plus sign, because the assumption is, at least behaviorally, that at this point she's behaving like a boy and cathecting the mother. That's why it's called the phallic Oedipal stage. And you will notice as well that in the scheme, in the positive square, this one here, the mother is written in capitals with 3 pluses, and the father is written in capital with actually 3 minuses. And the reason for that is to denotate the fact that at this point, at least behaviorally, the behavior seems to indicate that the cathexis of the mother with this masculine side of the little girl, the bisexual constitution of the little girl, constitutes at this point in time and for a limited period of time the most evident kind of manifestation of an Oedipus complex, and it shows in behavior, fantasy, in the type of the relationship for the mother, and so on. The negative square here, which is the one underneath, is not in capitals, and it has only 1 plus and 1 minuses, and the intention is to indicate that at this point, behaviorally, though the girl obviously has an enormous amount of femininity, she is behaving as if there is less of that femininity in the bisexual constitution, and consequently the mother is receiving most attention at this particular point in time. Now, it can happen, and it does happen, that on occasion, because the mother is not available or rejects the cathexis, the masculine cathexis, then both cathexis have to go to the object that remains and accept the cathexis, and that's the father, and the mother is a rival in the relationship of the little girl to the father, when the object of the opposite sex, which should be receiving the masculine cathexis of the little girl, is not available or rejects them. Then they have to go to the object of the same sex of the masculine constitution of the little girl, and that's the father. And that's why it has, in that case, both the positive and the masculine and the feminine cathexis will go and cathect the father, and the mother become the rival. Now, this is important for a variety of reasons. This first part of it is in fact the Oedipus complex of the boy. If you think about it, the boy, when he though here it is called the first stage of the phallic Oedipal stage, first stage of the Oedipus complex of the girl, and there is another significant step and a variety of other things that she must do before she completes the Oedipus complex development. For the boy, the first part of it constitutes all he has to do during the Oedipal phase. In fact, boy 2 has obviously bisexual makeup, where there is, in the normal conditions, a dominance of the masculine component, but there are some feminine components. Then the masculine components will look for an object of the opposite sex, that's his mother for the boy. And insofar he has an interest in the mother, the father is a rival again, because that's a larger amount of cathexis in his bisexual constitution of the masculine type. Then this square that represents the so-called positive Oedipus complex has the mother with capital letters and 3 pluses, and the father with capital letters and 3 minuses. That's with the masculine side of the bisexual constitution. If you take the feminine side, which the boy has, that the feminine cathexis of the bisexual constitution will look for an object of the same, of the opposite sex, and that will be the father. The feminine cathexis look for an object of the opposite sex, and that will be in this case the father. But because that is in a minority in terms of the balance in the bisexual constitution, then this is written father and mother are not in capital letters, in just 1 plus and 1 minus, like we did for the little girl. So this is the positive Oedipus complex of the boy, this is the negative Oedipus complex of the boy, which is always present. The Oedipus complex is a constellation that has a positive side to it and a negative side to it. In the normal condition, the positive side is largely dominant and the negative side is present, but is much less significant and less manifested in behavior, ego interests, and object relationships and so on, but it's always there. Under abnormal conditions, though, this can change very significantly, and sometimes, as we have discussed in the past, let's say if the heterosexual conflicts of his masculine cathexis and his interest in the mother become too significant as a defense, he might retreat from that position and behave as he has most interest in an object of the same sex, that is the father, than the mother, which essentially is saying, I'm not your rival, you don't have to hurt me, I don't want to kill you, I don't want to take mother from you. In fact, I like you, I'm like a girl, I mean, you should treat me like you should treat mother, yeah? And that is when the negative Oedipus complex become kind of oversized and overgrown. On occasion, as happens with the girl, as we said earlier, the mother doesn't receive the cathexis that are being addressed to her of the masculine cathexis, of the bisexual constitution of the boy for whatever reason. She may not be she may be absent, she may be dead, she may not be, the parents may be divorced, there may be no mother. And in that case, if the father is an object that is available, he will receive both the masculine cathexis that should have gone to the mother and the feminine cathexis of the negative Oedipus complex, and that we call the inverted complex, as we did in the case of the girl. Now, the inverted complex is kind of a substitution both of the positive and the negative complex when the normal positive and negative Oedipus complex cannot take place because there is nobody to receive the masculine cathexis of the little boy except for an object of the same sex. Now, there are some significant differences, as you will see, because if you think, and we are now talking of the boy, we will continue with the development of the girl to show the complications of it later on. If you think of the boy at this particular point, you will find that if the negative complex, this square here, becomes defensively, or because the bisexual constitution is such that there is a lot more femininity on this child than masculinity, or because developmental experience of a certain type, or like for example an active seduction of the boy by a male object, etc., may have determine a significant increase in this feminine component, then, as you will see, he will be looking later on, assuming that his ego has no objection, his superego has no objection to it. In other words, that this is egosyntonic and the superego doesn't really object significantly, or even if it does, there might be a resolution where he wants to take an object which is not a feminine object, that will be the reasonable thing for a boy to do, but a masculine object, and he wants to play the role of a female to that masculine object. In other words, he may end by playing a passive homosexual feminine role to another male, which is the object that he'd be looking for. And that's different from the inverted complex, because in that case, as you see, the dominant side of the bisexual constitution is the masculine one, and though there is some femininity, all in all, he's in a masculine position, but he's forced to look for an object of the same sex, a male. In this case of the Oedipus complex, of course, it will be the father. Later on, it be a male, not necessarily the father, a different male, but he will want to play a masculine role in relation to that male. In other words, he'd be looking for a male that be willing to play with him the role of a female. He wants to be the male in the relationship to another male that he expects to behave like if that person was a female in some degree. And that's the difference. In the inverted complex, the boy is relating to other males from a masculine position. In the negative complex, the boy is relating to other males from a feminine position and want to behave like a girl behaves to males. So as you see, there are significant differences, and this can manifest itself later on in behaviors, in object choices, in ego interests, in kind of activities that people will engage in and so on. So that's the boy. The boy then, assuming that he doesn't have to go into an inverted complex because the mother accepts the masculine cathexis and so on, and there is a father and he will take the feminine side of the bisexual constitution of the boy, which is obviously, as we have described, not as significant as the masculine cathexis. Then he has this Oedipal constellation that has positive and negative side to it, with a positive side that is a masculine behavior addressed to the opposite sex being the most significant and visible parts of the behavior. And that be normal. All he has to do then is at some point abandon the incestuous object model for a non-incestuous object, and that's all he has to do. He just takes a choice, he makes a choice of a feminine object, and that's it. That's a completion. He has completed the resolution of his Oedipus complex. He's now in a masculine position. He's looking for an object of the opposite sex that he will love dearly and so on, and that will be it. His erotogenic zone, which is his phallus at this point, his penis, remains the same, doesn't have to be changed. Now, that's a significant difference with a girl. If a girl were to remain at this stage, say in the positive, the first stage, the positive Oedipus complex of the first stage, it means that she will want to have a relationship with a woman, and later on that may mean a sexual lesbian relationship from a masculine position. In other words, she'd be an active lesbian in the sense that she will want to behave to a female like a male behaved to a female. She'd be the active masculine component of that relationship. If it were to be, now talking of the girl again, that she, for whatever reason, could not do the normal thing but had to go into the inverted complex at this particular point, and she remained fixated over there, then she will look for an object of the opposite sex, but she will behave towards that object as a male, not as a female. In other words, she will want to be the male in that relationship and will expect this male to be passive to her and in a way accept her as the masculine component of that relationship. And that, of course, will have all kinds of implications in later life and so on, and all kind of manifestation. Now, generally and normally, the little girl will abandon this first stage within anywhere 8 months to a year. She'll be moving over to the second stage, 6 months to a year is what this lasts, and she will move to the second stage, which is, properly speaking, the Oedipal stage. Now, the Oedipal stage then means that this masculine dominance that she has in the first stage changes in the second stage and become a dominant, her bisexual constitution, her femininity now comes to the foreground in full force and becomes very dominant. And this is very visible actually in behavior in children. If you are in a nursery school and they have very young children, you can see the transition from this position to this position. Here many little girls refuse to be the wife, they want to be the male in the relationship, and in the games in the nursery school will say, no, you are the mommy and I go to work and you take care of the babies, they will say to the boys. At this point, yet once they move in this stage, there is no way they are going to do that. They want to play the role of the mother, they want to take care of the babies, and they want the boys to go and play the role of the male and go out to work and so on. So they act this out, in fact, in front of your eyes in these scenarios. In any case, what we are saying then is that with her bisexual constitution, they have been achieved with the dominance now in behavior of a femininity is manifesting itself fully, as indeed is appropriate for a female. And with the feminine side of her bisexual constitution, she will affect the father. Insofar as she is interested in the father with her feminine side, a mother becomes a rival in that relationship, and again is to indicate that this is the dominant component of the bisexual constitution. Father and mother are in capital letters with 3 pluses and 3 minuses, but the girl is bisexual and has some masculinity in her, and that masculinity, the masculine side of her bisexual constitution, will go to the mother, and insofar as with the masculine side of her bisexual constitution she is interested in the mother, the father becomes a rival. to denotate the fact that this is less significant at this point than this other component. The words are written not in capitals and only 1 plus and 1 minus. Like it happened in the first stage, if by any chance the father is not willing to accept this cathexis and the mother is the only one to receive them, then the little girl will send both sides of a bisexual constitution to cathect the only available object, that is the mother. Yeah? But in this case, as you see, given that she is already in a dominant feminine position, she will be interested later on, assuming that this later becomes a preferred sexual position. She will become a female that wants to play, looks for an object of the same sex, a female, or want to play the feminine role to that woman. In other words, she's looking for another woman that be willing to play the masculine role towards her. She doesn't want a man to do that, she wants a woman to do that, to play the masculine role towards her, but she wants to play a feminine role to that other female. And that, of course, explains many of the different variations that exist in some of these relationships. As you see, because in this inverted square, both sides of the bisexual constitution are directed to the same person. Though the dominant side is the feminine one and she prefers to play the role of a female to the other person, it is not impossible that with a masculine side on occasion she may play a masculine role to that other object of the same sex. And now, so what we are seeing here is that the girl Oedipus complex has to be done in 2 stages, and that is an enormous complication. Now, further, she has to exchange the object mother for the object father. And in terms of the ego interest and ego fantasies, the ego interest and fantasies that correspond to this first stage, the positive Oedipus complex, where she has cathected the mother, has to be radically changed when the object mother is exchanged for the object father. That's something that the boy hasn't got to do. He chooses the mother. All he has to do is to find a non-incestuous object. The girl has to exchange the object mother for the object father, and then she has to find a non-incestuous object in order to achieve a normal sexual position. So as you see, that's more complicated. There is a change of the object. There is a change of position from a masculine position towards the mother to a feminine position towards the father, and later on towards a masculine object of a choice. And further that, the erotogenic zone that is dominant here is the clitoris. When she moves to this stage, and particularly obviously it doesn't happen between the ages of 3 and 5, because the vagina is rarely recognized at that point, but later on in life, once menstruation plays a role, and in some women it requires the birth of a first child for the vagina to take more significant, to move to the foreground in a more significant way, then she has to add to the clitoridal erotogenic zone, which still remains essential for her orgastic capacity, the vagina. And so she has to modify somewhat her perception of her own genitals and the role that they play in sexual interaction, all of which is something that the boy doesn't have to worry about. He doesn't have to enlarge his erotogenic zone. It remains exactly the same, and so it goes. Now, this is important because in the past, some people made the assumption that if, in fact, some analysts, a famous analyst by the name of Maria Bonaparte, had the idea that if women did not achieve what were called vaginal orgasm, it was because they had a dominance of the clitoridal area of the erotogenic zone of the female genitalia, and she recommended that the clitoris will be dissected out, which of course make an orgastic discharge completely impossible for female, because that is essential. The role of the clitoris as an erotogenic zone is essential for the orgastic capacities of females. Now, so that's very significant, because there was the whole idea that women should reach what were called vaginal orgasm, and that is an absurdity. There is no such a thing. In fact, the vagina is their vaginal orgasm, but it's through a mechanism that involves the clitoris. Without the clitoris, there can be orgastic discharge. And what happens is this: in the act of sexual intercourse, when the penis goes in and out of the vagina, there are some ligaments that go from the lower part of the vagina, the lower part, to the clitoris. And there is a hood that covers the clitoris. This is the clitoris. There is a hood over it, and there are ligaments that go back here to the entrance of the vagina. It's the labia minori. When the penis goes in and out, it pulls this ligament, and that means that it produces a rubbing of the hood of the clitoris in the clitoris, and that sensation at some point gets, when it acquires a certain degree of intensity, is referred to the spine, and the spine produces sudden vasoconstriction, and that sudden vasoconstriction is in fact the orgastic phenomena of the female. Previous to that vasoconstriction, the pelvis had been engorged. All of the pelvis area has been flooded with blood, and even the genital areas, the labia, for example, have been enormously engorged. And suddenly then, at this particular point where the intensity of the sensation reaches a certain point, then that spinal center sends a message that produces sudden vasoconstriction, and that sudden expulsion of all that blood out of the pelvis and the uterus and so on, and the walls of the vagina and the labia, is the orgastic sensation of the female. Clearly, if you take the clitoris, that can happen. So, vaginal orgasms are possible as long as there is a clitoris. Otherwise, if the clitoris is removed, that will not happen. Unfortunately, there are cultures, even today in Africa, where this practice is common, where women are taking the clitoris is taken out of women. And the reason for that are obscure but interesting. And it is quite likely that the reason is that males have some kind of fear of the female's sexuality, mostly because males' orgastic capacity is much more limited than that of women. A male can have an orgasm, but then requires a rest period to recover, which when he's very young may be something like 20 minutes or half an hour. As he ages, maybe more hours, and as he really becomes older, maybe days. And so, in contrast, some women are quite capable of having a repeated orgasm, one after the other, in quick succession, which conveys a feeling, it seems, to some males that they are not capable of gratifying them sufficiently. And that practice is probably aimed at reducing the orgastic capacity of the women so that they won't be unfaithful or something of that nature, which is of course an absurdity, but is indeed practiced even today in some, certainly in Africa, for example, in some places that is practiced. So, as you see the complexity of the Oedipus complex, in girls is considerably more than that of the boy, and that's why there are a lot more difficulties in human female sexuality than there are in males, female, in male sexuality and orgasmic capacity. It's a much more balanced and delicate mechanism, and they had a lot more requirements that just male sexuality does have. Now, all of these tend to happen between the ages of 2.5 and 5, and that means 2.5 is a little early, but some children are very precocious and move, if it is a girl, into this first stage of the phallic Oedipal phase at around 2.5 to 3 years of age, or a little later if they are not that precocious. But it happens, let's say, between 2.5 and 6, the whole issue of the Oedipus complex as a phase that must be resolved at around 5 or 6 years of age will take place. Now, as you know, with the resolution of the Oedipus complex, the authority of the parents is given to the superego, and then the superego has the authority to impose its commands force the ego into certain behaviors, which was a capacity that it didn't have before it acquired the parental authority, and particularly the father's authority into itself. So that's a significant part. The other thing that is important to remember is that by the time this has taken place, an enormous amount of development has taken place in terms of the ego cognitive capacities. And as you remember from previous lectures, when we were discussing these things, this is at that point that the ego can then reorganize all the conflicts that took place in the earlier phases of development, and instead of having to fight in a large variety of fronts, it consolidates it into a specific unit, which each one of the conflicts of the different phases get represented, and that constitutes the first neurosis, the infantile neurosis, which is normal. We all have to go through that. Whether it is normal or not depends on the vicissitude of the earlier phases and on the conflict that can arise in this phase, but we all have to go through that infantile neurosis. We all develop an infantile neurosis and the symptoms that go with it, but they tend to be, if the development up to that point have been reasonable, they tend to be not very alarming, and they don't create serious psychopathology later on. If there have been problems in the oral, phallic, anal, and in the phallic Oedipal phase, then that may be a different situation, and instead of the normal infantile neurosis, you will have an infantile neurosis that is already tainted and is already pointing to psychopathology, and this is indeed the first edition of all later adult neurosis that will take place in this human being life. So all of these developments take place in relation and in coordination with developments that take place on the ego side as well, in terms of ego resources that are acquired, and that's what gives the ego the power to organize all these different conflicts into one unit that is called the infantile neurosis, which is a highly economic development, and because it forces the ego to fight only one front rather than in 25 different conflictual areas. And obviously that has enormous economic advantages. So that's important, just as it is important to know that with the resolution of this complex, the superego authority is finally acquired, and it becomes more operative. It's more capable of imposing its commands than it was before. And of course, this type of phenomena, whether it is wherever it is that the fixation may take place for whatever reason that it takes place, will determine the sexual identity of people and what kind of preference people will have, what kind of choice of objects they will make, what kind of ego interest they will have, what kind of sexual gratification they can enjoy and allow themselves, and so on, what is conflictual, what is not, and the rest of it. So these things are of enormous significance. In order to understand these phases well, it's important to have a look at in the web page of the center to the lecture on the Oedipus complex, which is considerably more extensive than this one is. All of this, incidentally, is based on a book that I wrote many years ago called on female sexuality and the Oedipus complex. Now we're going to leave that subject and move to the issue of arrests in development, fixation, and regression. This is extraordinarily important, obviously, just like the previous subject we were treating, in terms of understanding how the psychoanalytic theory of the neurosis is really understood, and how neurosis get organized, and which are the elements that go and influence the final form that it will acquire, and what are the conflicts that will lead to one form or another, or and so these things are of extraordinary importance. The question of arrest in development, fixation, and regression is similarly important, because the final form of the adult neurosis will be largely dependent on which fixation points have been established in the course in the progression of development towards the phallic Oedipal phase, and if they are very significant, they will shape not only the course of further development, both in the libidinal and aggressive side of these issues, but ego-wise and super-ego-wise, and will determine the quality of the object relationships of which this individual will be capable, will determine what kind of resources, ego resources he can use, what kind of ego interests he will have, what kind of fantasies he be proliferated in the mind, what things he's capable of doing, what things he be inhibited about, and so on. In fact, not only determine the form, the final form of the neurosis, that is what is to develop as a result of all of these problems and conflicts that are possible during development. But even in normal cases, in people that achieve normality in adulthood and don't develop a significant neurotic problem, they will determine a lot of the characteristics of the personality of that individual according to the different stress of the different component instincts of the different phases as development progresses, and the struggle that took place to take these, to resolve these conflicts and continue developing in a normal manner. But obviously, the balance between the intensity of the genetic givens and the environmental influences that acted upon these genetic givens, the outcome will determine what kind of personality, character, structure one develops, and again, what kind of ego interest, what kind of object relationship one is capable of, what kind of inhibitions one will be subjected to, what kind of resources we can use, and so on. Now, because the fixation points and the regressions to such fixation points play such a significant role in the form that the final neurosis and psychopathology will take, we will spend some time discussing these issues. Arrest in development, a total arrest, is rare, but it does happen on occasion, and what it means is that either the libidinal or the aggressive development, or both, got stuck in a particular phase of development and never move forward to the phallic Oedipal phase. Now, that is not common, but is conceivably possible, and indeed, on occasion, for one reason or another, that is possible. Frequently, the problem is that there are some ego lacks or defects which somehow contribute to the inability of the progression of the instinctual forces in the right direction, or because enormously traumatic situations or events can take place in the life of some unfortunate children that may lead to an arrest in development of enormous significance. It's rare that it be 100%, but it's large enough that it probably can be considered for all intent and purposes really that something that arrested development in an earlier phase and didn't allow it to complete the progression through the different phases. Fixation, we have talked a little bit about this in the previous lectures. All it means is that one gets stuck somewhere. As you remember, we were talking of the oral phase and the two subphases, the anal phase and the two subphases and the phallic-oedipal phase. And each one of these phases has a large number of different component instincts. And when one talks of fixation, it is important not only to say to what phase the person is fixated, but to, once you say that, and that is good, that you can say, well, it's an oral fixation or an anal fixation or whatever it may be. On top of that, it is important if you can determine to what particular component instinct or component instinct of that phase the fixation really applies, because it generally is not across the board to all the component instincts of a particular phase, but to some of them. And the conflicts are specific to these component instincts, and so the struggle between the defense and the component instinct that lead to symptom formation and to neurotic conflicts is very specific, and in terms of treatment it's important to be able to get to the genetic roots of the symptoms that are observable in the clinical picture that are in fact derived from this conflict at this particular point in time. So fixation, on the other hand, is a concept that applies not only to libidinal development. The same is true of the development of the aggressive drive. One can be fixated to certain stages of ego development. One can be fixated to a certain point in the object relationships. One can be fixated in a primary narcissistic stage and consequently not develop sufficiently into the object relationship world, and in fact have either narcissistic character disorder or narcissistic personality disorders of one type or another, and so on, so that the fixation applies in many ways to different aspects of human development, whether it is a fixation in terms of the drive, a fixation in terms to a phase of ego development, where it is a fixation in the development of human-object relationship at a certain stage, whether it is an insatisfaction state or a stage where the person has reached object consciousness, and within object consciousness the various sub-stages that characterize it and so on. But it is important always to not only refer to the phase, as I mentioned a moment ago, but to try and then dissect within that phase, if possible, specifically to what particular component instinct the phase, the fixation has taken place. Now, how does one clinically assess the fixation points? And typically in the past, many analysts thought that you don't have to do this in the diagnostic or in the initial diagnostic interviews. Through time and the analysis, you will find this little bit by little bit. And that was actually at some point by some people assumed to be the only way that you could do this. We don't believe that's the case. We believe it is important to ascertain as much of the fixation points or the regression that has taken place or the arrests that are visible in personality structure, because then you have a plan, you have an idea of how that neurosis got built up, where the genetic components of it lie, what the roots of it, where they extend to, what are the conflicts that created what you see now in adulthood and needs to be dealt with. And of course, if you have this at the beginning of the therapeutic intervention, you have already signposts as to what it is that is important in this particular patient, where the possibly sources of conflicts are, what the possible component instincts are, and why we observe whatever it is that we observe in the form of symptoms, even inhibitions, abnormal object relationships, and so on. In other words, we are oriented as to where the main work will have to be directed to or conducted, and how to get there, and how to deal with the resistances that are on the way to getting to that point. In any case, the fixation point is reasonably easy, particularly in children, to ascertain, because let's take for example sucking, which is an oral manifestation. All babies suck their thumb, and at some point give it up and go on with the development. Yet there are some children that don't do that. They keep sucking the thumb, and they need that very badly indeed. They are 7, 8, 10, 12 years old, and they are still sucking the thumb. The normal course of events is that it they tend to hide it on occasion, but when the fixation is very significant, they do it in front of anybody, visitors, friends. They don't hide the behavior at all. So it depends on the intensity of the phenomena that created the fixation, the intensity of the fixation, or the intensity of the sucking component instinct, the way it will be observed, and there are obviously enormous variations. But it's simple. Obviously, when the child moves from the oral phase to the anal phase and then to the phallic-idipal phase, his sucking of the thumb should have been left behind. He moved to a different stage, and the manifestations of the early phase should be left behind. In people that has a fixation, let's say to the sucking instinct, it can be any of the component instincts of the oral phase, you continue to see the manifestations of that fixation, of the activity of that component instinct at a time where it is not usually seen and is not normal to be seen. So if you have a child that is 5 and is still sucking his thumb, you know that he has an oral fixation, and that oral fixation is to the sucking component instinct of it. And if you see that, you know that there were some problems at that particular point in time during the oral phase that led to that fixation. Because one of the basic tenets of the idea of fixation is that it takes place through two different mechanisms, either by excessive gratification that leads to fixation, or by excessive frustration that leads to fixation as well. So the best solution is in the middle, which avoid excessive gratification or excessive frustration, and that generally avoids the fixation, the establishment of a fixation. So how do you know? Well, you know that because you know then that the child or an adult or whoever it may be is fixated to a particular component instinct or a particular phase, because you see the manifestation of the component instincts that are normal during that stage in development at a point later or many years later where it shouldn't be observable any longer, because they should have been left behind, and they have not. So at that point you can say, well, obviously he has a fixation point, look what he's doing, you know. Now it's a lot easier with children than it is with adults, and the reason for that is that the fixation point is still there in an adult, but as I was saying earlier, there are certain displacements that take place that may hide the fact that the person is fixated. For example, that may change later on to sucking of the thumb may be to sucking candies, and later on it may be to smoking, whether it is cigarettes or cigars, and that's, in other words, as people grow, and this obviously become conflictual, to be seen, sucking your thumb in public is not acceptable. But to have a cigar in your mouth and suck at your cigar is acceptable socially. So the fixation finds ways to achieve the gratification in ways that are less conflictual than the direct expression of the instinct by sucking the thumb or anything of that kind. So obviously there are all these changes of expression. In some people it may be overeating, for example, or a variety of such phenomena. On occasion it's even hidden further, because what happens is that instead of it hides in some people in their sexual relationships. In other words, for example, some people with strong oral sucking needs will only manifest those during their sexual relationships, and then sucking will play a very significant role for them. In some extreme cases, it will be the main interest in their activity, to the point that it may substitute for the genital activity completely, and all they are interested is in sucking or being sucked at or whatever it may be in that case. Obviously, in that case, it's a little more difficult to ascertain the fixation because it's hidden during the sexual relationship of human beings. But when you have a patient, if you are alert to these things and you see the early manifestations of the fixation, you may well suspect that he had gone into hiding somewhere, and then you may ask a relevant question, being tactful and obviously considering whether the patient can really, at that particular point in time, be asked these questions and is capable of giving you an answer without being too embarrassed or too, ashamed of it or whatever it may be. So it's not all that difficult to do it, but it does take a certain amount of effort and the ability to take a carefully thought out developmental history and asking for certain specific questions that will highlight these things. So the fixation is relatively easy to establish, and obviously some people have fixation in a particular phase of development. Let's say the oral phase, but no problem in the anal phase, no problem in the phallic Oedipal phase. Well, that fixation point will shape the later phases. For example, take somebody who has a significant fixation, oral fixation. When he gets to the phallic Oedipal phase and he will experience castration anxiety, the form he will take will be fear of being beaten, an animal beating off a part of his body. In other words, there is the oral element, something, there be a bite that will damage your body and take away your penis or whatever it is. Some kind of body damage that will be the equivalent of the castration anxiety. And so that's obviously very important and significant, and the early fixations always will play a role in what happens in the later phases and will somehow manifest itself in the later phases of development and give them some slightly different form or shape, but they are clearly visible. They change the form of expression of the conflicts of the later phase and kind of paint them with the colors of the fixation in one form or another. Same is true in terms of ego development. obviously, if you have certain types of fixation, oral fixations and so on, it is very likely that your ego fantasies, your ego interests and so on will be significantly influenced by the fixation. So at the range of your interest, some people will go in, I don't know, into cooking or whatever it may be, which is somewhat related to this. In other words, these things shape a little bit the personality structure as it develops, though they are not always determinant, but it may, in some cases, that may be the case. Now, the regression then typically goes to, let me finish this. If there is, some people have only fixation in one phase, the oral phase, or the anal phase, or whatever, the phallic Oedipal phase, and they are better off. Obviously, the higher the fixation point, the better the prognosis. The earlier the fixation point in development, the more severe the prognosis of the treatment is, and the nature of the conflict, and the more damage that it may have done to personality development. So obviously, oral fixations are more serious and severe than anal fixations, and then certainly the phallic Oedipal type of fixations, which are less troublesome and problematic, but they can lead to symptom formation, and neurosis is the same. The prognosis is better the higher the fixation, because development has completed itself better the higher people have gone in the development. In any case, some people, though, in the course of development, unfortunately, develop fixation at every phase, in which case, then later on, when they develop a neurosis as adults or adolescents, sometimes even in late latency, they have what is called a mixed neurosis, which means you can observe elements of all the phases: oral phase, anal phase, phallic Oedipal phase, and all of them are there together and manifested themselves very loudly in severe cases. Of course, the ideal situation is the one where no fixation point is really established, the phallic Oedipal complex is resolved, and then you develop a reasonably normal personality. Now, if you think of fixation vis-a-vis regression, we know that regression takes place always to where the main fixation points are. Again, let's say that somebody has some fixations in the anal phase, but not too much, and very significant fixations in the oral phase, and he gets into trouble when he gets to the phallic Oedipal phase, and there are severe conflicts there. Well, as you remember in an earlier lecture, we will use a metaphor of a general in the army that takes his troops over there and find that the enemy there is more powerful than he is, so he goes back to where he left some of his troops in the fixation point at the anal stage. And if the numbers there balance the other, he probably can stay there. If still he is not strong enough, he may have to go to where he left most of his resources when he got fixated, because that means that there is an active conflict there, and many of the resources of the personality are invested in keeping it at bay. So not only do you go up weakened, carrying a load, so to say, carrying a lot of luggage, but you have left a lot of your resources tied down in the fixation point. And so you reach the higher levels already compromised, and conflicts at that stage can force a regressive move. The regression will take place to the most significant fixation point in the last resort. If possible, it's somewhere in between, but generally speaking, if the conflict is very severe, the move will go all the way down to wherever the fixation point is that is established. Now, that creates problems. As you remember, we talk about that many of the conflicts in the developmental progression, when they take place at a year and a half, 2 years, and so on, the ego and the superego doesn't have the kind of objection that by the age of 7, 8, or 20 will have to the manifestation of these impulses. And so with the regression, because there is an increase of these activities, then even the superego will be horrified by what is coming to the fore at that particular point, and the conflict is very severe. In any case, how do you determine the regression? Well, it's relatively simple. Take the case of the child that sucks his son, and maybe the mother will come and tell you, yeah, he, doctor, he used to suck his son, he never gave it up, and then he was 7, 8, 9, and he was sucking his son, but what he did is because we were on his case all the time, he only did it in his room, or we were not around, and so on. Now suddenly, in the last year or so, he is back at doing this anywhere, in the street, in a shopping mall, when there are visitors at home, when everybody is in the living room, and there is no way of stopping him. In other words, what you see is an increase in the activity, which delayed, showed that there was a fixation point, because he had been sucking his thumb all the way through, but all of a sudden the intensity of that activity has increased tremendously, and he's doing it more, he's doing it all over the place, he's not ashamed about it. While he was ashamed before and hide it, now he does it everywhere, he's compelled. Usually, if you take a good developmental history and they tell you, well, about a year ago he started to do that, then you can find out what the elements were at that particular point in time that triggered the regression. And by finding out what were the events at that point in the life of this individual or that child, whatever age it may be, then you may get some important information as to what was the nature of the problem that induced a regression. But essentially, when there is a regression, what you see is an increase in the activity that was observable and was making the fact that there was a fixation very obvious. So that's the way you generally do it. It's not all that difficult to do. It requires a careful taking of the history and things of that type. Now, I wanted to read you a little bit of what I wrote on this paper on addressing development, fixation, and regression that is published in the Psychoanalytic Study of the Child, Volume 19. And this is to summarize, and then I will read you maybe one or two examples. The existence of fixation points is indicated by the ever-present manifestation of the earlier phases at the later stages, far beyond the age at which such behavior corresponds to specific stages in development is accepted as normal. Their intensity and activity will be proportionate to the amount of libido and aggression arrested. The reinforcement and intensification described above correspond and are proportionate to the regression that has taken place. Hence, the extreme importance of taking a very careful developmental history of the child, in which one tries to follow as closely as possible the vicissitudes of his drive development and even of the specific component instinct operative in the various phases, especially when there are indications of any kind of interferences with normal development. Now, let me read you at least this one example, which is from actual life. It was a case that we saw at the Hampstead Clinic many years ago. This was actually a 4.5-year-old boy that was in a diagnostic interview. And let me illustrate this, how regression and manifestation manifest themselves in the clinical material of the diagnostic interview of one of our cases at Hampstead, where no special effort was made to sort out what belonged to fixation or regression. Is given to you. I shall single out from the clinical picture presented by this by this 4.5-year-old boy, the elements point to his oral fixation and how they show all through his development up to the present day. In this case, it is further possible to point out the regressive reinforcement of the oral manifestation that seemed to be due to the unhappy confluence of a number of events in his life, one of them at least of quite a traumatic character. Jay, which was the name of the child, was described by his mother as a hungry baby. Already as a baby he was unusually hungry, who had to be given supplementary bottle feedings, which means he had quite an appetite, and that's a genetic given. He was breastfed for about 6 weeks, at which point the mother developed a breast abscess, no doubt related to the intensity of the sucking of this child. When the mother tried to reintroduce breastfeeding later on, Jay seemed to prefer the bottle, clearly because he could get a lot more out of the bottle than out of the breast, and this was a very hungry baby. He was weaned from it with no apparent difficulty at about 9 months. At 16 or 17 months, he showed a marked dislike of chewing and would spit out his food. His mother claims that he always tended to dislike new foods and that he has had different food fads. So you see all the difficulties during the oral phase. She recalled a week's visit to Holland when Jay was 22 months old. During that time, he could eat nothing at all, but had cornflakes and toast only. So the trip triggered off this reaction. At present, that's 4.5, 2 years later, he still sucks his thumb when he's tired. If it is of interest to observe how the child spontaneously introduced the subject of food by himself in his diagnostic interview with the psychiatrist by referring to his brother Simon. Quote, "My brother, Simon, was really a rascal because he said that you must not eat more than 3 Easter eggs. But Simon ate 13 of them." End quote. At another point during the same interview, he started to make a square cage for hens and sang, quote, "Will you like me an egg for my tea?" End of quote. All the above clearly shows the ever-present fixation. When he was about 3, a number of events succeeded each other. His entry into nursery school, a hospitalization for tonsillectomy, and the birth of a sibling. Since that time, his feeding difficulties increased. The social history says the following, quote, "The mother made it quite clear that since his operation, the feeding difficulties have seemed worse. He's finicky, but the mother sees to it that he gets a balanced diet by preparing meals which she knows he likes." Here the mother's account clearly points to the regressive reinforcement of the earlier fixation point due to the tonsillectomy, which obviously has some traumatic consequences for him. Essentially, that's mostly what I wanted to refer to in terms of fixation and regression and the manifestation of these, how you see them in the clinic, in interviewing patients, and of course, if you develop some skills to ask the appropriate questions and so on, once you see some manifestations of problem in the face or in relation to a particular component incident, then you will get a much more clearly evident picture of where the fixation points have been established.